analyst. I'd like my own data analyst.
Sounds good. Thank you. And then we'll go to Molly. Molly Vixie.
Hi, it's Molly Vixie. I'm Manager Population Health here at St. Mary's, Providence St. Mary's here in Walla Walla. We're running out of Epic, and gosh, let me tell you, I would really love some dashboards within Epic that were accurate and recorded outcomes correctly so that I could pull all this lovely data that everybody is doing and be able to report on that.
Good wish. I like it. And Alex, are you able to talk? Okay, I saw a note that you might be in transit. So we'll go on to Stacy George.
Good afternoon. My name is Stacy George. I'm the Director for Quality, Population Health, and Utilization Review at Community Health of Central Washington. We call it CHW for short because it's very long, but CHW is an FQHC. We have 5 clinics between Yakima and Kittitas County, and we use Ocean Epic. That's new to us as of March of 2023, so we're still learning how to use the system. If I could have one wish, I would wish for one more nurse care coordinator on my team.
Awesome. Thank you, Stacy. And we get to hear more from Stacy later too. And so we're going to go on to Rachel.
Rachel, I'm the Population Health Manager at Catholic Medical Group here in the Tri-Cities, and you're on Epic as well. I agree with Molly Vixie that we don't get great reports. My wish would be for my own data analyst.
Thank you, Rachel. Okay, let's see, Liana.
Sorry.
Not hearing you, Liana, if you're talking.
Oh, we use Epic, and I mean, I agree. We could use a data.
Okay, Leanna, you're breaking up, but I heard you say, I know you're from Catholic, and that you guys use Epic, and your position is in population health. I'll share that for you in case people didn't hear it. And you would like to have a data analyst to help with getting all these reports that are needed these days. So we'll go on and Kim Selsler.
I am Kim Selsler. I am one of the regional clinic managers for CHCW with Stacy George. We are, like she said, FQHC, and we're on Ocean Epic. I would love to have a community health nurse is what I would love to have.
Sounds great. Okay, and who did I miss? Oh, Carly. I see your name here. Carly Port.
Hi, yeah, I'm Carly Port. I'm the Chief Physician Service Officer at Pullman Regional Hospital. And so we have a network of clinics, primary care, we have a family medicine residency clinic, and then a variety of specialty clinics. We use Epic. Probably another nurse care coordinator would be our wish.
Okay. Okay. Well, we'll go ahead and move on. I thank you so much. And I think that sharing is quite valuable, really helpful to know. I think sometimes as we're learning about each other in the cohort, that you would be able to reach out to another site that has Epic, or if someone has this Athena or things like that, it might be some information that you won't have to, you could have help figuring out something. You don't have to recreate the wheel. That's the hope. So I'm going to go ahead, and it is not at all. I only have we have an hour altogether, and I really want you to hear some sharing from Stacy and from Sarah, and I want us to have some discussion time at the end. So my information here is going to be pretty high level, and for some of you, it's really old news. But back to basics for those of you who are quite advanced in empanelment. But I'll go ahead. And empanelment defined is just simply stated the act of assigning an individual patient to an individual primary care provider. And it's a process for sorting patients into populations, and it's a way to manage supply and demand. So just going to move on. So sorting patients into populations is quite valuable, as you all know. It allows for the group of patients to be easily identified, whether or not they're in for a visit. So back in the old days, I think, patients just showed up and you didn't really always have a lot of history on them or understand maybe they'd seen different providers if you're in a group. So this, whether they're coming or not, they're still, we're able to do things for them, reach out to them about preventative care or with education, those types of things. Second of all, allowing a provider and team to customize their services to the needs of their specific clients. So once you have an empaneled patient group, your team working with that patient can decide how they want to share the work, setting such things as setting up standing orders, allowing for people to work to the top of their licensure, maximizing your time as a provider with a patient, and also empowering others to do work that they are able to do and enjoy doing. Also, the third one is allowing for the determination of performance regarding specified quality metrics. So we do that, of course, as a whole with patient populations. It's kind of fun sometimes to be able to look at individual providers and how they're doing with some of the metrics, and allow for some channeled energies with what works for their specific patient population, and even allow for some competition sometimes between providers. Good, healthy competition sometimes can lead to better managed patients, and that's always fun to see. So one of the very first steps that is important in empanelment is defining what an active patient is. So different organizations have different ways of saying that who's an active patient and who's no longer an active patient. So I would just like if a couple of people could share what their definition is of an active patient. I'd really appreciate it.
We use 18 months. We have a two colleges close to us, and so that helps us to gauge the most realistically of patients who are continuing to seek our care.
All right, thank you, Carly.
Laurel, at Lord's, we tend to use 3 years. So if someone's been seen within 3 years, they're still considered an established patient.
Okay.
And that's the same for Community Health of Central Washington. It's 3 years.
3 years, okay.
Same.
I'm sorry, Rachel, what'd you say?
3 years for Catholic as well.
3, okay. So the 3-year people, is that related to like coding, so that if they're beyond 3 years, if they haven't been seen, then you're able to code for a new patient, or is that just arbitrary 3-year point?
No, that's correct. If it's been 3.5 years, they're coded as a new patient.
That makes sense, yeah.
And Laurel, we do that too for our coding and kind of how they're established, but when we're defining our patient panels. So I don't know if I understood your question right.
No, you got it right. It's just, when you read in the literature, there's just a full gamut of different ways to do it. And I've seen 2 years a lot. And I'm like, I wonder why, like why would, what is the cutoff? So I think it's interesting to share within organizations of the why. You gave yours, which was, with the transition of students coming and going, that 18 months is what makes sense for your organization. So thanks for your sharing. Okay. So the next slide I have is like, if sometimes if we're starting out with a patient population and we haven't had them defined as who's their provider is. This is a 4-cut method. It's been around for quite a while. And I'm not going to read it all to you in the interest of time, because some of you are probably quite familiar. But I'd also like to say that this is also a method that can be applied periodically. So if you're adding a new provider to your practice and you want to relook at panels and see if everyone's assigned or not, or as part of practice, the primary care transformation pilot, we are wanting people to assess their panels, and the pilot says on a quarterly basis. So I know it's difficult, and sometimes organizations have it that they're shooting for an annual basis to look at panel sizes. And so part of that process, the beginning place, is to just pull that report, make sure that if everyone is assigned a primary care provider, and then go from there to see who's unassigned, and then use a method such as this to help assign them. Another important step in this whole empanelment process, it's valuable, is once that you've established these patient lists for providers, that if providers can take, or teams can take a look at them and say, we've never seen this patient. That's kind of difficult when you're looking at 1,200, 1,500, 2,000 patients on patient panels, but it's one of those steps that helps if it's possible for people to, the provider teams to look at. Any comments? Does anybody use a process like this for when they're looking at their assigned patients for PCPs?
We don't have it charted out like that, but essentially we do that. So I took a little screenshot. I think just the chart
did
is helpful in like a step by step. Yeah. But
Okay.
essentially that's what we do.
Okay. And it's kind of all of this information, Carly, you guys will get the slide deck. But also I've given resource links as we go through so that you can have the resources. And you'll see there's one resource that is just so valuable. It's the Safety Net Patient-Centered Medical Home. There's a whole guide on empanelment that it's older, but it's amazing. Like, even though it's an older resource, that it's kind of brings you back to the basics, because we go through so much in healthcare, so many changes and so many things that you're like, you forget your starting point. So I think that even though it's a lot of the things in this resource are simply stated, it's quite valuable to have it all in one place. So as many of you are probably aware, one of the aspects of empaneling a provider is to understand if they have good enough access. So if patients are able to be cared for. Maybe organizations are not able to add any new patients to a provider for a prescribed amount of time. This gives you an objective way to look at it. Again, this is super simple, but it's kind of fun to actually plug in some numbers for your providers and see where they end up. We all know that we're sorely understaffed when it comes to primary care providers in our area of the state, in our area of the United States. So, we're going to see probably pretty large numbers, but it's good to know. It really is. So it's just, you're looking at this formula of provider visits per day. So how many appointments are available for patients to be seen in a day, times clinic days in a year, which, that's taking out their CME days or vacation days, or, they're going to be on a leave, how many days in that clinic year are available to be seeing those patients. And these are all just rough cut numbers. I mean, there's huge varieties of depending on what's going on. That's balancing with the number of patients. So unduplicated patients, within the time frame that you pull the report, if it's a year. And then you need to know your average patient visits per year. So again, it's from pulling a report and looking at patient visits to see what the average is. And you'll notice differences according to provider. So one provider might pull patients back in, I want to see you in 4 weeks, or another one might say, okay, I'll see you in 3 months, but call and let us know if you need anything. Or maybe patients are managed more from a patient portal, so they're not seeing patients as often. But there's so many variables. I cannot speak to them all in the time frame that we have. So how does this look like with plugging in numbers? So we have provider visits per day here are 18, days in the clinic are 210, and average patients per visit year is 3.6. And just to have a moment to speak to that. A number I've seen out there for many years is a 3.19 number of average patient visits per patient per year. If you look at different, I have in the resource I'm going to give you, you'll see a little chart. And again, it's not brand new. It's not relevant to this year of information, but it's kind of interesting to think about. So for internal medicine, 4.5 visits per year, family practice 3.5, and pediatrics 2.8 patient visits per year. So, and babies are coming in more often for their well visits and immunizations and things, but then as they get to be adolescents, it's annually and they're healthy generally. So, you're going to see different numbers there. And so that's where it's good to pull your own reports for that wish list that you had when we started out of the data analyst. You say, hey, can you just run that for me? I'm curious today. But some of us have some data analysts that can give us this type of information, and it is valuable to look at. So in this case, you ran those numbers and it came out to 1,050 is the number of patients that provider with their schedule set up with their templates, the way that they look, would be able to see. And for that, with that 3.6 average visits per patient. Of course, we have all of these variables. Again, you have no-show rates, you have longer appointments, you have shorter appointments, you have weather sometimes, impeding your ability to see patients or for them to come in. So it's just a rule of thumb. It's just a way of looking at things. And I think it's important to mention. So any questions or comments about these strategies for looking at supply and demand? Has anybody used this?
Yes, we use this. This is basically the formula we use every time we compute a panel for one of our docs.
Okay. Thanks, Dr. Taylor. It's pretty simple. I mean, as long as you can pull the reports, it's quite simple to look at, and it is really valuable because even if you're not closing a panel, I mean, you still can have an understanding of how what you're asking of that physician. And then when you notice patients are saying, I can't get into this, my primary care provider, and you see them bumping over to other provider schedules, it really would behoove you to look at, this panel size. So another step, so we talked about supply and demand and assigning patients to a primary care provider. I briefly hit on reviewing it with the teams to see if that's who they think their patients are. But the last step would be risk adjusting. So I alluded to it a bit when I talked about internal medicine versus family practice, but that also just has to do with your patient population. You might have demographics in your area where you have a higher percentage of retired people or a lower percentage of retired people, or like Carly, a lot of college students that are in and out. So, risk adjusting your panels is another tricky but very valuable way if you can look at your patient populations to see, you might have, say, 3 or 4 internal medicine providers, and 3 of them are just trucking along. They're seeing their patients on time, and they're, able to see new patients and all of that. And one of them just feels exacerbated all the time, like he's completely exhausted and just can't seem to keep up with all the tasks and the follow-up and referral coordination and those types of things. Well, if you risk adjust, you might see that the acuity of one provider's patients, they may have many with comorbidities or a higher percentage of more elderly patients, that type of thing. So assigning some basic way of risk adjusting your clinical panels, that is also quite helpful. And it's hard. I think everything with this is you can do what you can, but just being aware that it might help solve some problems by looking at that, at the data. So I guess I'll stop there. It could go so deep. Some of these, even one topic we could spend probably an hour on about something like this, risk adjusting your panels. But just bringing out the topic, just realizing that it's there is just something that I want you guys to be aware of. if you're not already. Some of you could teach me about all of this for sure. The resource for empanelment, I have the link here for you. It's the Safety Net Medical Home change concept of empanelment. I actually have it printed, from being patient, a provider navigator for practice transformation. But within the empanelment, they give you the steps. There's all these like really neat charts. It talks about if the percentage of time of spent on preventative care, chronic care, acute care by a provider that does everything themselves and doesn't have team members help them out with some of the education or keeping up with, delegated tasks, I guess, are the important concept here. Then the panels can actually be larger if you have a really high functioning team that have great delineation of who's doing what and patient flows. Everyone is more satisfied, and all of that goes smoother for the patient as well as for the team. So that's kind of the whole picture. This empanelment is a building block for a lot of the concepts that we're talking about with primary care transformation. The care teams, the referral, closing the loop on referrals, the self-management support, all of these things they build off of this basic building block of having teams, having patients empaneled to their provider teams. So, okay, so that's the resource. In the resource, there's ability to click on things, and there's actually an Excel spreadsheet for determining the right panel size. So again, it's kind of fun just to plug some numbers in and see what it looks like. There's also some sample policies in there that are, you can't take a policy and change the name and put it, because organizations have so many specific processes and policies and staffing things that it wouldn't work, but it would be a beginning spot to say, oh, I don't have a policy structured like that. It's a beginning place to take and go, that makes sense to have something for scripting for our call center staff that are taking new patient calls that are looking for a primary care provider. I need to get that in place. So, and these are, like I said, really simple things, but they're available on this website, and it's kind of a one-stop shopping. It's kind of nice to have them all in one place. There's lots of other resources out there, and I can, if you have a specific question, I can help you find some resources if you need it. So I'll pause there. Any comments or questions? Okay, so basically, really basically, you have all of your patients empaneled to their providers. And another concept that's really important is risk stratification. So the idea is, okay, so you have this list, and this is what all of you are working in population health are aware of, that you take your patient list and then you can put some type of parameter to risk stratify. So sometimes organizations do something as, if they have 2 chronic health conditions and they have polypharmacy and greater than 10 medications, then they apply that across their patient population, and the report that comes out shows patients that are most at risk or according to those parameters. And that's what you're choosing to do, to put resources towards those patients to help them manage their care more appropriately, or you have more staff providing reminders or medication reconciliation, those types of things. So this is just a super simple list of things that possibly, could be applied across the patient population to risk stratify. There's you guys can't read this, but I've given you the link to look. This is a very good article, I thought, about risk stratification. So again, it's pretty simple, but sometimes that's what we need, because if it's simple, it applies to more organizations than if it's a really elaborate article. What this is showing is the AAFP, the American Academy of Family Physicians, have used this type of risk stratification tool. So it's looking, if you look at the low risk, low claims history, low severity according to ICD-10 or HCC codes, the EHR and health information database. For utilization, no ED visits or unplanned hospitalizations, and then clinical, no chronic health conditions. So those are going to be our really low risk patients, as opposed to if you look at the high risk, you know, lots of claims, lots of higher acuity ICD-10 codes utilized, 3 or more ED visits, any readmission, those types of things. And then over to the right, they have, you know, simply levels 1 to 6. And so then you would identify, you know, with those level 6, patient potentially in danger or dying or being institutionalized within the next year. So it's a pretty neat way of risk stratifying patients and then deciding how you want to apply your resources to those patients highest at risk. And there's been lots of studies on this, and this particular method has been used across many organizations. So it's kind of nice to look at something like this and know it's already been tried and trusted over the years. And there's like really complex ones out there. Some of you are probably quite familiar. But I just thought this was a kind of a nice one to show to you guys and give you the reference. So this is the example that they're showing of a different care plan that's applied for the different level of risk that's applied to the patient. And so you can see, you know, the level 1 versus the level 5, you know, just how many things that you're doing for your level 5. So they're throwing a lot of resources to try to help that patient to maintain or improve their health. So I don't know if anybody has seen that before. Okay, so time check, we're at 1:30, and I would like to get some information out to you of how people are doing some of this work. Everybody is that I have now met with all of the clinics that are participating in our cohort, and have become more familiar with especially many of the strengths. And so I would like to go ahead and ask Sarah if she could let us know what she's doing in her role at Lourdes and what information she has to share with us. So Sarah, I've already stopped sharing my screen if you want to go ahead. And we're thankful you're here.
Thanks. I have a couple of PowerPoint slides and then a couple of spreadsheets that I just kind of will show you a little bit about. Hopefully I click the right one, screen, and okay, can you guys, oh, it's loading.
It's coming, yeah. And I didn't introduce, but Amy Smith from Greater Health Now is backing us up here. So she actually has your slide deck if you need help with it, if we have difficulty, Sarah.
Okay. Still says it's loading. Are you guys able to see it quite yet? Oh,
Yeah.
There it is.
Got it.
Hooray. So as I've already introduced myself, my name is Sarah. I'm a nurse navigator, and I work at Lourdes. There are 2 of us. Our other nurse navigator is Charissa, and this role started in about 2019, I believe, late 2019, early 2020. And it was decided, and this was before I started, it was decided that the nurse navigators were going to focus on following up on patients who hit the ER or discharged from the hospital. And the first nurse navigator came up with a lot of really brilliant workflows and started us down a path that has molded and grown and changed over time into something that's, I think, is quite wonderful. So she started by looking through our EMR Athena and getting records of patients who went to the emergency room from our EMR. So most of the time, if a hospital knows who the PCP is, they'll push records through, and then that's how we would get the notification. But that relies on the patient being alert and awake and able to say, yes, my doctor is Dr. Adling, and he's at Lourdes, and could you please send him my records? And so there was a lot of things that got missed with that. And what we did was we had this really rudimentary Excel spreadsheet. Can you guys see that?
Mm-hmm.
Yes.
Okay, so, we just, and it was all entered by hand from these records that we were getting from hospitals. So we would see who the PCP was, their name, their medical record number, where they went, when they went, what they went for, and contact and follow up and things like that. And it was kind of fun to look at this very old spreadsheet because this is, one clinic, 1 month, and it had like 137 ER visits. And we're now at over 400 ER visits a month. So it's definitely grown. And one thing that has helped us to be a lot more accurate is working with Point Click Care, and they used to be known as Collective Medical. And what we do is we, our very brilliant data analyst pulls a roster of all of our current patients who have been impaneled with one of our providers and have been seen within the last 3 years. She puts it into an Excel spreadsheet, and we upload that to Point Click Care, and they search everywhere for our patients, not just locally, but all over the country. We get notifications from Massachusetts and California and Texas. It's quite wonderful. So the first thing I do every morning is I log in to Point Click Care, and this is the page that I see, and it shows kind of a snapshot. We've got, okay, ER visits, ED discharges, how many patients have been to the ER 3 or more times in the last 3 months, 5 or more times in the last 12 months, how many discharges we've had, admissions, behavioral health, and SNF admissions. So it gives us kind of a very quick, breezy overview. So I kind of glance at that, and then I click on scheduled reports, and I get a screen that looks kind of like this. And every single day we get a report of yesterday's data. So we get one for inpatient and observation admissions and discharges, and one for emergency room admissions and discharges. And it looks kind of like this. This is an inpatient observation one, and it shows all of my patients, what clinic they belong to, where they went, when they arrived, when they left, what their diagnosis was, how many times they've been to the ER in the last 12 months, how many times they've been admitted in the last 12 months, and their risk of being readmitted once they get discharged. So that's really helpful for us to kind of figure out who we want to focus on for follow-up. And we keep track of all of this on what we call our master roster. And there's 2 of us, so we use it in SharePoint. And it is a big, huge Excel spreadsheet that has a lot more information now than it used to. I think I've got some columns hidden. So we go by month. We look at when the last time they were seen by their PCP, because are they due for an annual exam? Are they about to fall off our radar? Do we need to schedule them for a follow-up? Whether or not they need an ER follow-up to make sure that they stay on our radar. We know where they went, when they discharged, what their diagnosis was. So this is our ER roster. We keep one for inpatient and one for ER, and we look at how many times they've been to the ER, what their triage score was. 4s and 5s, if you guys know about the ESI scores, are typically do not need to be in the emergency room. They're very low acuity, and so that lets us know that that patient's misusing resources and they might need some education. We make sure records are pulled for everybody. We notice if we sent them to the ER, we want to follow up. If they were prescribed medications like antibiotics or steroids or narcotics, then we want to follow up with them for that. If they were referred to a specialist and we can't find that they actually contacted that specialist, we want to make sure that we help coordinate all of that. We're unable to keep up with every single patient who goes to the ER anymore because we have an average of 401 ER visits a month. So this is how we kind of decide who we follow up with and who we don't. And there are going to be patients who don't technically meet criteria, but our nursing brain says, no, I'm worried about this patient, I'm going to call him anyway, and we call him. And what makes this, using this in Excel, so helpful is that we're able to pull all of this information and follow up and show exactly what we're doing to administration or, CFO or whoever wants to follow up and make sure that, how we're spending our time. This shows for the entire year of 2023 for family practice, how many patients went to the ER, how many met criteria for follow-up, how many were contacted, scheduled, and attended. We were able to calculate how many days after their ER visit patients are actually seen in clinic when they schedule a follow-up appointment. We look at the billing code that was used when the patient followed up and are able to calculate, I blacked it out because it's kind of financial information, but we're able to get a guesstimate of how much reimbursement ER follow-ups have made us in the last year. We have a value-based contract with Medicare. We're part of the Medicare Shared Savings Plan, so we pull information for those patients. And it's the same, how many patients went to the ER, how many met criteria, how many got called, scheduled, and attended. And then we look at who is the payer for our patients who are hitting the ER. And, you know, most of our patients who hit the ER, the highest number is Medicare, followed by Blue Cross and Molina. And that kind of surprised me that Blue Cross was in there, because Blue Cross has a pretty big copay for an ER visit. But they still, a lot of those patients are still going. And so if we can focus on those patients and teach them about coming into the clinic and getting their care through the clinic, they could save a lot of money and get faster, better, more continuity care. We can also create charts for hospital discharges and TCMs and billing codes and where our patients are discharging from. And if they don't show up, why don't they show up? And so it's been a really helpful tool for us, and it's really grown a lot over time. And this is just a piece of what we do. We also have, you know, a pharmacist that looks at patients with polypharmacy. We have all kinds of really great things, but this is kind of the nurse navigator follow-up protocol.
Okay, so that is wonderful, Sarah. I always am enthralled to see that you guys are doing this work. Does anyone have a question for Sarah?
I know I went through it really fast.
You did a great job.
There's a lot more detail to it, but that was me trying to squeeze it into 10 minutes. So
yeah, you did great. Okay. Rachel, yeah, go ahead.
Sarah, I know that we've struggled with getting a lot of useful data out of this program. I wondered if you would be willing to meet with me and the person that actually uses this and kind of walk us through how you got it set up.
Did you catch that, Sarah?
Are you talking about point click care, Rachel, and making it useful for you?
Yeah.
I'd be happy to tell you anything and everything I know. I love point click care. I would not be successful in my job without it.
Fantastic, thank you.
And I just, you know, Sarah and I have had this conversation a couple of times. I know there's another one of our sites in our cohort that is also interested in how to maximize their use of point click care, because some of you are paying for this and you're not getting what Sarah's getting. So I know, Sarah, one of the things you mentioned to me was like you did a lot of work initially to get what you needed. You want to talk about that for a minute?
Well, we had to make sure that our empanelment was accurate and figure out what information they needed us to upload. And those reports take a really long time to pull. So we were uploading them quarterly, and we ended up having to increase that to monthly because patients transfer care or expire or establish care. And so to keep that list as updated as possible, we upload a new roster every single month. And we tweak the reports that they pull for us, and it's an automatic thing. It's there every day when I log in, and it's you know, when we were told to start risk stratifying hospital discharges, I found out that collective or point click care does that for you. So they have some kind of formula that they put in that risk stratifies the possibility of the patient being readmitted. And so sometimes I disagree with what their formula comes up with, but it's a good jumping off place and way to kind of just prioritize who I'm going to follow up with first. So, and we still go back and forth and ask questions and update things. It's updated a lot over the last almost, 4 years?
Okay. Thank you, Sarah. All right. So I really appreciate that. And we also have Stacy George, who has her hand up, I think, now that I see that.
I do have my hand up.
Did you want to ask Sarah a question or?
I did. Yes.
No, I'm sorry, I missed it.
No, you're you're good. No worries. We also use point and click care, and but I've learned from your presentation we really have not maximized how to use it. So I would love if you would be willing to. I heard somebody else ask also if they could pick your brain, and I would love to be part of that conversation if I could.
Absolutely. Yep.
That'd be awesome.
Yep. I'm here to help anybody who needs help. So.
Okay, this is good. And so, you know, just to say, our last slide is going to be having you guys do the evaluation, which includes what you want more information about with this shared learning webinar. So I'm more than happy to tweak this to what you guys need and want to be more successful with the primary care transformation pilot. So it sounds like this might be one of the topics. Just saying, Sarah, no pressure. But you seem to have you know, cracked the code on this very valuable resource. So anyway.
There's parts of it that I'm underusing, I'm sure. I mean, you can upload care plans into there, and anybody who has point click care and can look at that patient can see the care plan that's there. They have, you know, reports that print off every time the patient hits the ER that says, hey, this patient is seeking, please don't prescribe narcotics. And there's all kinds of really cool pieces in that.
That's good to know. Okay, we'll go ahead. Stacy George is from Community Health Plan of Central Washington. And I'm so delighted to have her also. I mean, we really do have a great cohort, you guys. I just hope that I can help you guys get to know each other and maximize resources that you all have to offer. So with that, I will go ahead. Stacy's the Director of Quality, Population Health and Utilization Review, and has been doing, they are PCMH recognized and has been doing this work for a long time and certainly has my respect. So go ahead, Stacy.
Thank you. Good afternoon, everyone. I'm gonna share my screen with you. Let's see. Okay. Can you guys see the presenter mode of the?
I can see, yes.
The big one?
Yep, the big one.
It's like up on 3 screens, so I'm not sure what you can see. Okay.
I know, yeah. Go ahead. You got it.
All right. Thank you. Let's see. I'm just getting my screen organized here. Okay. Good afternoon, everyone. As Laurel said, my name is Stacy George. I'm the Director for Quality, Population Health and Utilization Review for Community Health of Central Washington. And I'm just going to share with you a little bit of overview of our risk stratification and care management work that we do in our population health team. So a little bit about CHCW. We already answered some of these questions at the beginning, so sorry, it's redundant, but we are an FQHC in Yakima and Kittitas County. We have 5 primary care medical clinics, and we serve about 30,000 patients annually. We really work to reduce barriers for patients getting access to care, and so we have a lot of integrated services. We have a MAT program, which I didn't even think of as using as risk stratification, but I guess that's what they do until today. But we have a really great MAT program. We have integrated primary care behavioral health at all of our clinics. We have pharmacy on site. We have imaging on site. 2 of our clinics are a residency, host residents who study under our wonderful faculty docs. We have occupational med for a group in Yakima. We have lab on site at all of our clinics. And then of course, our population health team. So CHW has been doing some kind of risk stratification since 2017. So I'm going to kind of walk through what we have done and what we've stopped doing and what we're currently doing, and just share all of that with you. So we got our first nurse case manager, is what we called them back then. Now they're care coordinators, but the case manager, I think in 2015, and she primarily focused on meeting with patients who were newly diagnosed with a chronic condition, and also did a lot of diabetic education, even though a diabetic educator wasn't really a thing back then. But we knew that we wanted to kind of beef up our risk stratification and case management. So we, in 2017, really grew our population health team and began onboarding some more RN care coordinators and also social workers to do risk stratification and case management. So we started with looking at HCC codes, which is a Medicare methodology of risk stratification. And so really looking at those patients with those really high level risk codes related to their HCC codes. And then we have pediatric patients and we have a pediatric clinic. So we couldn't find any peds that way. So we also looked at the CDPS payment system, which is a Medicaid risk stratification methodology, so that we could identify those patients who, those pediatric patients who could also benefit from some extra case management and support from our nurses. I would run the risk reports quarterly and give them to our nurses, and they would do outreach to patients to offer case management by way of monthly phone calls. Most of our work was done over the phone. We also, at that time in 2017, started doing chronic care management, which is identifying patients who are Medicare, so they're usually 65 or older, with at least 2 chronic conditions, and they are enrolled in long-term case management with monthly phone calls. And then we also started the Health Home program, which is ran by the Healthcare Authority, and they use PRISM scores to identify patients. It's really based off of utilization. So these are patients who are really either really overutilizing the healthcare system or really, really sick and appropriately using the healthcare system. But either way, their use is what's costing a lot of money to the healthcare system. And so we in 2017 also started offering Health Home to patients. So we built our care plans to make sure they were meeting the NCQA PCMH requirements. So for all of these, when we would have a case management call, the care plans included the problem list, goals for the patient, barriers the patient might have to being compliant with their goals, medication management, plans for follow-up, all of those kinds of things to ensure we were staying compliant with PCMH. What we've stuck with, we have stuck with chronic care management and Health Home. And really, there's a couple of reasons why, but those are both and continue to be evidence-based case management programs. And they're also billable. So when you're hiring a bunch of nurses to do this work, it's great to be able to bill for these services. And so chronic care management and Health Home, you know, we are able to see the patient outcomes. There's a lot of data you can find that support these methodologies for risk stratification and case management. And so we have continued with those because they were really, we've seen positive outcomes. We really struggled with the HCC and CDPS methodologies for risk stratification for a few reasons. Mostly, and this is going to sound a little bit awful, but I'll explain. They identify patients who are really, really sick. When all you're looking at is these HCC codes or these CDPS codes, they're identifying patients who are super, super sick. And I would give our nurses lists of patients to contact, and they would already be receiving case management elsewhere. They would call 40 or 50 patients a quarter to offer these monthly phone calls and case management to. And these people were sick enough that they were already getting case management through their payer or through a specialist or through Seattle Children's. And so it wasn't really value added work. And so I kept like lowering the threshold for risk. And then you end up calling patients who don't really want it or need it. You know, and so it was like a lot of work just to find patients to case manage. And then they weren't really the patients who needed case management. So for a while, our team, we kept doing it, but it just didn't feel super fruitful. And so really the kicker was that in March of 2023, we went live with Ocean Epic, and we no longer had the interface with the reporting registry that I used to do risk stratification. And so it was at that time kind of on pause, and we definitely could run it again this way now, but that is something we've identified that it's not an area that we want to move forward in risk stratification using just those codes. So what we are working to improve, we are working to improve our chronic care management. We want to ramp it up. Chronic care management, for those of you who are unfamiliar, Medicare has a copay. They have a $16 a month copay for chronic care management, and people don't want to pay it. They love the program, but they don't want to pay it. So for a long, long time, we've really only outreached to patients who had Medicare and a secondary insurance. And so we've been working for like the last 2 years, trying to figure out ways where we can help people who can't afford the copay or incentivize people with like gift cards to pharmacies, or how do we get people who are Medicare only enrolled without that burden of the copay? And so we've really been working on that and have a plan that will hopefully be able to roll out soon. Right now, we serve about 1,200 patients in chronic care management, and we could very easily double that. So I'm looking forward to that. With the Health Home program, the Healthcare Authority has guidelines and best practices about what panel size your care coordinator should have. And we have very exciting news that we've had lots of health home babies this year in population health. So our caseloads are really small right now. And so we're working on, everyone's back from their maternity leave, and we're working on ramping up those panels again, and possibly investigating some contracts, a new contract. We have contracts with 4 MCOs right now to do health home. And so we're looking at possibly adding a 5th. We are looking at how we can utilize, there are patients in the clinics that would benefit from case management. And so how do we develop our own methodology for risk stratification? If a provider says like, oh, this patient could really benefit from some extra nurse attention or social work attention for a couple of months, how do we know that? What do those patients look like? And then also, how do we graduate them from being in case management and getting these monthly touch bases? So we're working on that, especially for our pediatric population, looking at asthmatic patients or patients newly diagnosed with ADHD, and kind of trying to figure out ways that we can better support that population. And then finally, our nurses also do a lot of work around transition care management. So we are looking at really high utilizers for the emergency department, using point click care to identify patients who have had 3 or more emergency room visits in the last 3 months. And we are wanting to dive into and learn more about why they chose the ER over their primary care. Are there social determinants that are impacting their decision to go? Do they know about our after hours call and our extended hours? Really, what's the barrier to getting them in? Is it because they don't have a relationship? Do they not feel like they see their provider? We want to learn those things so that we can learn how to improve, and then also try to help connect the patient with resources that could, reconnect us all, improve that relationship with our patients. So that is kind of where we are in our risk stratification and our case management process. So that's it. Any questions?
Yeah, Stacy, I have a question. This is Kevin Taylor. I'm intrigued by the fact you have 1,200 patients on CCM, and you could easily double that, you said. So tell me how you have managed the nursing brain or the expertise to be able to develop the care plans for that many patients. Sounds like a lot. Can you comment on that, please?
Yeah, so we are tricky, and we actually contract with a third-party vendor. We have a really, really great relationship with a company called MD Ally, and they are experts in annual wellness visits and chronic care management. And so they have nurses who do these monthly phone calls for us. It still is very lucrative for us, even though we're paying obviously MD Ally to do the bulk of the work. We have a nurse in our population health team who reviews the care plans for those 1,200 patients at least once annually, and is kind of that middleman. So like if the nurse care coordinator at MD Ally is talking to a patient and the patient has questions that nurse can't answer, or they want to schedule or anything like that, they have access to our EMR, and they send messages to our RN care coordinator who does the chronic care management. He's kind of like the middleman between those care coordinators and the clinic. And so he, knows all those patients well and those care coordinators not well. But that's been a long relationship. We meet every Wednesday morning with the folks from MD Ally, the care coordinators, to make sure that we're all in sync on what we should be doing and how to take care of patients, and everything's flowing back and forth well. And it's a really huge service that we can offer to our patients. But again, it is very financially, it was a really smart decision to go that way because we can serve all these patients.
Well, that's good to know. Do they charge per patient or per hour, or how do they charge you?
They charge per patient. And so over our 5 clinics, our Yakima Pediatric Clinic, they don't have any patients enrolled in chronic care management, obviously. So over 4 clinics, I get invoices every month where they send 2 things. They send basically a big list of all the patients who are enrolled, how many phone call attempts they made and how many patients they were able to reach out to. And then it's pretty much a 50-50 split. So when we bill Medicare, we pretty much keep half of what we're reimbursed and we pay MDLI half.
Thank you.
Mhm.
Would you be able to share that resource with us, please?
Yeah.
Thank you.
Gladly.
Thanks.
I have another question about that, if that's okay.
Yeah.
I know we're over the time, so if we need to end, I can reach out later, but
Let me just say real quick, Sarah, we can continue for those who want to. And then if all of you could please take time to go into the chat and click on the link to do the evaluation and tell me what you want to hear about in the future. But go ahead with your question, Sarah.
so with these third-party chronic care manager nurses, do they get assigned, does each patient get assigned one person to kind of have a relationship with, and they, you know, build a rapport and all?
Yeah, they have the same nurse care coordinator call them every month. They end up with like really amazing relationships. Same with our health home program. People love, you know, just having one person that they can talk to, and this kind of elderly population loves to chat with the nurse care coordinators. They share some really nice stories. But yes, there is one nurse care coordinator who is assigned a panel at MDLI.
And are you able to show any data showing like improved outcomes from chronic care management or anything?
There's a lot online that you can find. We are hoping with our old EMR, we didn't really have any data, and I was sad to hear people in this call saying that that Epic doesn't have good data. I have found it to be tremendous. Maybe that's just because of where we came from. This is great. But I'm really hopeful that in the population health world, and not just in chronic care management, I am really wanting to be able to hone in more on like, you know, what pockets of patients is our work equitable, and are we really making a difference? And so that is one area that we want to look at too, is like if somebody's enrolled in chronic care management and they, you know, are continuing to make goals around improving their A1C level, like, is it working? And Medicare has a lot of research that shows that it does, but internally we do not. We haven't had that reporting structure.
Okay. Thank you.
Stacy, thank you so much. It's just so valuable, really. Yeah, I mean, within this cohort, there is just so much value. And I guess that would be my hope, is that we can continue to have this kind of sharing of resources, of best practices. And I think that that would really help enhance what you're each trying to do. So I hope you feel the same. Please go ahead and I am sharing my screen to show you some ideas about future shared learning webinars, but please put what you would like. And we look forward to hearing from you. And we will meet again next month. So we'll look forward to that, and appreciate all of your time today. And I will go ahead and close and say thank you.
Thank you, Laurel.
You're welcome, Molly.
Thank you.
Thank you, Laurel. Bye-bye.